Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me once again Dr. Jeffrey Zondor, who's been kind enough to help us on programs in the past. He's professor of medicine, Department of Oncology at the Carmenas Cancer Institute at Wayne State, and he's a national and international expert not only in myeloma but in a field that is even more challenging to treat, and that's amyloidosis. So we're glad to have him here. So welcome, Jeff.
Thanks, Ravi. I appreciate the invitation to come back and speak with you.
So I guess for our audience to start off with, what is amyloidosis? I think that's something that you obviously have built a very impressive uh, uh, track record in treating, and I look forward to learning from you about this disease and how you treat it.
Thanks so much. Amyloidosis is actually a whole group of diseases, and what all of them have in common is there are abnormal proteins produced in somebody's body. And these abnormal proteins, they misfold and they get sticky and they spontaneously form these strands and clumps that can deposit in different body tissues. And the symptoms that patients have depend on where those protein deposits land, what organs end up being involved. If you click out to the next slide, we can actually determine the type of amyloidosis by doing special testing on a biopsy usually. Um, this slide basically shows a technology called mass spectrometry, which involves actually like dissecting that abnormal protein off of a biopsy sample and then analyzing it to find out what the protein is. And then we can give it a name. And different types of amyloidosis are treated in different ways. And so this first step, the correct typing, super important.
So, as an oncologist, we generally treat AL amyloidosis, but I understand you have actually also been treating a broader variety of amyloidosis other than just AL amyloid. Is that fair?
Yeah, that's correct. I mean, um, AL amyloidosis, as we're going to talk about, is actually a blood disorder, a plasma cell disorder that's related to a type of blood cancer that we treat, multiple myeloma. Um, but the other most common type of amyloid is called ATTR or transthyretin amyloidosis, and there's different forms of that even. There's inherited forms, and then there's age-associated forms. And just, distinguishing AL from ATTR, since those are by far the two most common types of amyloid, again, the most important first step because there are actually FDA-approved therapies for both of these types of amyloid, and they're completely different. And so you would never want to give somebody therapy that doesn't have any chance of benefiting them, but you also don't want to accidentally give them therapy that has the potential to cause side effects, right? So, um,
I understand there are cases where people just assume that this may be AL amyloid because of light chains and abnormal proteins, but they have coexisting amyloid due to ATTR when you do this mass
right.
spec test that you have talked to us about. Is that, do you find that?
That's exactly right. One of the blood tests that we use, or one of the ways that we sort of hone in on the possibility of AL amyloidosis is some abnormal blood or urine tests looking for something called light chains or elevated light chains or an elevated M spike produced by plasma cells. But by far the most common condition that causes those markers is a completely benign condition called MGUS, way more common, dozens of times more common than AL amyloidosis. And so, sometimes a person who just has plain old MGUS that doesn't actually need treatment also has ATTR amyloidosis. And it's a lot more common than we think. The demographics have a huge overlap. Plasma cell disorders like MGUS and AL amyloidosis and myeloma are more common in African American people, more common in older people, and those same demographic groups are more likely to have ATTR amyloidosis as well. So that's right. Sometimes I mean, we really strongly recommend that you try and do this kind of tissue typing in almost all cases. There are exceptions. where just imaging and blood tests can be enough. But for the most part, we try and actually get tissue typing.
So as far as AL amyloidosis goes, I guess we're going to focus more on this subvariety during this
Yeah.
talk going forth. So what do we know about AL amyloidosis?
Well, it's a plasma cell disease, like I mentioned. All of us have plasma cells in our bone marrow. Usually, it's 1 or 2% of the cells in our bone marrow. These are the cells that make antibodies. And you can broadly divide plasma cells up into two main types: types that uh, have antibodies with kappa light chains as part of them, and another type that have antibodies that have lambda light chains. It's not so important what kappa and lambda light chains really are, except to say that usually we have a mixture of the cells that produce each type. So we call that a polyclonal situation. That's a normal sort of array of plasma cells. And like I said, these are the cells that make antibodies. So they're an important part of our immune system. If you click the button, though, what we can see here is a situation where one bad acting plasma cell, something happens to a plasma cell that leads it to uh, grow and reproduce in an abnormal way, producing an overabundance of cells that are all of one type. So in this case, it's an overgrowth of plasma cells that are lambda light chain restricted. We call this a monoclonal situation. So where they're all derived from one original bad acting cell, and they're all related. They're all descendants of one another. This is the situation where this is the situation that arises, for instance, if you click the button in multiple myeloma, which is a plasma cell cancer. These cells are reproducing so aggressively, they sort of overrun the bone marrow, and then they cause problems that we see commonly in myeloma. We teach medical students and our colleagues about CRAB criteria. It's an abbreviation for the kinds of things we see: calcium elevation, renal or kidney injury, anemia, and bone lesions. We don't generally see those problems in amyloidosis. If you click the button, amyloidosis, it's also a clone, an abnormal clone of plasma cells in the bone marrow, but it's not usually totally overgrowing the bone marrow and causing these crab type symptoms. What happens is these clonal cells make misfolded light chains. I already mentioned that they tend to stick to each other and deposit in organs. That's what we're seeing on the far right, these tissue strands. But in between, when they're produced in those strands, there are these misfolded light chains circulating in our system and actually sometimes being taken up by different organs and injuring those organs. And that's one mechanism of injury for the heart and for the kidney, among other organs. And so it's both the circulating soluble misfolded light chains, and it's also those sticky clumps that end up deposited and filling up the organs as well. Both of those things injure the organs in patients with amyloidosis.
So I guess you just embarked upon telling us about the organ injury. So I guess we can expand upon that.
Yeah, I mean, any organ can be involved. The most common ones are the kidney, heart, liver, and nerves, but other tissues can be involved. And if you click the button, I already sort of mentioned this, that it's not just the deposits, but the circulating cells. And we can measure the way organs are injured and how they're responding to therapy if you click the button by doing certain tests. There's some kind of imaging tests that give us hints, like echocardiograms of the heart or other more involved imaging like MRIs. But for other organs like the kidneys or the liver, and even the heart, we have blood or urine markers that we follow that show us what the degree of organ injury is. And generally, when therapy is working, we see those markers become more normal over time. So we track how organs are responding to treatment as
So
part of
blood
our
tests
assessment.
are, I guess you're saying, the major way to track them. Do you do serial echocardiograms or other imaging tests?
So it's common for patients to get uh, sort of like repeated rounds of imaging or that kind of testing over time. But the real time assessment of organ response, like let's take the heart as an example. NT-proBNP is listed here. That's a blood test. And that's an easy thing to check, like on a monthly or every 2 month basis, and you can get a very real time assessment of how the heart is responding to the disease and to the treatment for the disease. Yeah,
So I I understand that time is of the essence.
that's right. So, um, organ involvement is what makes amyloid patients fragile and hard to treat, and um, it there are certain types of organ injury that set in motion uh, almost can almost set a patient in like a vicious cycle right out of the gate. The degree of heart involvement on the day that you're diagnosed actually is an important factor in determining how you do subsequently, your survival as you're being treated. Also, how injured your kidneys are on the day you're diagnosed actually is one of the strong predictors of how likely it is that you might end up on dialysis. So there are staging systems for both the heart and the kidney, um, that we employ when we're talking with patients about prognosis. The earlier you diagnose somebody, the better. The less organ injury they have, first, the more likely they'll be able to tolerate treatment, and second, the less likely they already have this sort of irreversible injury in place that leads to problems down the road.
So what are your goals of treatment?
Well, there's two basic goals. The first is to get those abnormal toxic light chain levels as low as possible, as quickly as possible, and for as long as possible. By doing that, you reduce the risk of ongoing organ injury, and you maximize the chances that a patient's body will be able to heal itself and the organs will start to repair. But so we give treatments targeting the plasma cells that are making the light chains, and that in turn knocks down the light chain levels that we measure in the blood. So think about it as like targeting the factory that's producing a dangerous product rather than trying to mop up that dangerous product. In the meantime, though, that's the fast part. We're able to generally get light chains down pretty quickly, but organ recovery takes a long time. Sometimes it lags behind by 6 months, 12 months, even longer. So if you click the button, so like supportive care to manage the symptoms like protein leakage in the kidneys and congestive heart failure, numbness and tingling in your hands and feet, or problems with your blood pressure, like all of those things are pretty commonly seen in amyloidosis. And so we really need a team of specialists. Most amyloid patients have a cardiologist, a nephrologist for their kidneys. A lot of them have neurologists or gastroenterologists, in addition to people like me, hematologists that are giving treatment targeting the plasma cells.
So it's a team approach. It's one of those where you just can't do it just yourself.
It should be. I mean, it's such a complicated disease, and some of the problems like congestive heart failure and low blood pressure can be so difficult to manage. Managing one, aggravates the other, and vice versa. It's a very complicated thing, and so getting not every cardiologist or kidney specialist in the country is an amyloidosis expert, but you need to find somebody who is at least engaged and really willing to roll up their sleeves and take part in a patient's care.
So how do you talk about
Response.
hematological response?
So when patients, nowadays patients can see their labs, right? Everybody sees their labs on a portal, and so that you can, light chain testing is a blood test, and when you see a light chain report, it shows you the level of the kappa light chains, the lambda light chains, and then it gives you the ratio of these two things. And what you don't want to see is a huge excess of one versus the other. The like if we go back to the example I showed you where those lambda plasma cells were overgrown, In that situation, when you measure the light chains, you'll see a very elevated lambda light chain level in the blood, but the kappa level will be normal. And so the ratio will be abnormal, but when we're assessing response, we're focused more on the difference between them. So in this graph right here, the difference between the free light chains, DFLC, the pink one would be the lambdas and the green one would be the kappas in our example. But it could be the other way around too. It's individual for each patient. So this is our starting point. And if you click the button 3 times, I can show you. One more, perfect. You can see different degrees of response. There's a partial response, a very good partial response, and a complete response. And what you can see each of these response levels really is the deeper you suppress that involved bad acting free light chain that turns into amyloid, the closer you can get it to the level of the other light chain, the better. And so we shoot for the tighter responses. It's critical to shut down ongoing organ injury and give patients the maximum chance of improvement in organ function and, frankly, improved chances of ongoing survival. We need to get those deeper responses. So we like to see at least a very good partial response or better when we're treating patients. That usually happens within the first couple months of starting treatment using therapies that target the plasma cells.
So what are the therapies?
Yeah, exactly. So there's a lot of them. So the idea of this graph isn't to go into every single one of them, but what it shows you is that there's a lot of different classes of medications, and all of the therapies, or most of the therapies, certainly all of the ones on the left side of this graph, are therapies that were developed to target the plasma cells in multiple myeloma, which is a plasma cell cancer. And just like in multiple myeloma, what we generally do is we sort of pick and choose from different categories of drugs to create cocktails of therapy that hit those plasma cells from lots of different angles at the same time. And I showed an example here of a 4-drug cocktail, one antibody called daratumumab, 2 chemotherapy drugs in the middle, and a steroid, dexamethasone. Dara-Cybor-D. That's an example of a 4-drug cocktail. And how did we pick it? It's not completely random. If you go to the next slide, we actually study these cocktails. So we did a trial. Click on the button for me, where we used this combination of daratumumab, the antibody, plus the Cybor-D chemotherapy steroid cocktail. And we showed when you added all 4 of these drugs together, almost 100% of patients had an improvement in their light chains. The response rate was 96%. That means 96% of patients had at least a 50% improvement in the difference between their free light chains, and about half the patients had a complete response where there was no difference between the involved and uninvolved light chain. When we saw that in this safety run-in study, we did a randomized study where we actually compared 3 drugs versus 4 drugs. And if you click the button, I can show you adding that 4th drug really changed the efficacy of the regimen. Remember, we're trying to get those deep responses. So if you just look at the complete hematologic response rate, more than twice the complete hematologic response rate when you add just that one relatively non-toxic antibody drug and then use it as maintenance therapy by itself. So this 4-drug cocktail is the only FDA-approved treatment for amyloidosis, and it's based on this study showing that that 4-drug cocktail is way better than the 3-drug cocktail it was compared to. Go to the next slide. So, again, that's the heme response. We saw those responses within the first few months of therapy in the majority of patients. What did that translate into for organ responses later? Like what happened? If you click on the button, you can see that in heart and one more time kidney, right? You can see that improvement in the heart markers that we follow and improvements in the kidney markers that we follow. Again, click on the button for me. About twice the likelihood of having improvement in organ function if you add the antibody. So that higher rate of complete response directly translated into a much higher rate of organ improvement. And with improved organ function, we expect better long term outcomes for these patients. Less cardiac deaths over time, hopefully, and also less patients who end up, in complete, renal failure on dialysis. It remains to be seen. We're still in early follow up, but it's very, very encouraging that we're seeing these higher organ response rates and also significantly lower rates of actual deterioration of these organ functions as well. So,
But
this
these
is
take a while to show up in
it does. So,
patients.
yeah, no, it absolutely does. This is, again, organ function at 6 months relative to the start of therapy. But these patients had hematologic responses, improvements in the light chains within a month or two. So this is lagging behind. And actually, this is actually relatively quick. Like I said, sometimes organ responses take a whole year to be seen.
So obviously, you've talked to us about this one and only FDA-approved regimen. So how do you think through when you see a patient as to how you're going to approach this particular patient in terms of incorporating this regimen or other approaches in the treatment?
So it used to be that the first decision point was right after diagnosis. We'd say, is this a person who's fit enough to have high dose chemotherapy and a stem cell transplant or not? And you would, if they were healthy enough to do transplant, you'd send them straight to transplant. And if they weren't, you'd send them for a regimen like Cybor-D or Cybor-D with daratumumab. Now, most patients are starting this four-drug cocktail right out of the gate. And the patients who aren't transplant eligible just get this for 4 to 6 cycles and then go on to get maintenance therapy with daratumumab alone. Or if they're transplant eligible, they come back to a decision about whether or not to proceed with the transplant based on how things are going with the four-drug cocktail. It's becoming increasingly common when a patient's already achieved that major hematologic response early, increasingly common to sort of kick the possibility of transplant down the road. Now, if you click the button, you can see that in sort of both sides of this first column, if patients don't achieve that very good partial response in their light chains or better, the advice most of us give is to modify therapy somehow. Now, for a transplant eligible patient, that might mean at that point coming back to the question of transplant. Or it might mean moving to other drugs from other columns in that treatment table that we had. And so that would include, if you click the button, that would include drugs like lenalidomide or pomalidomide, which are commonly used drugs in multiple myeloma but tend to be used later in amyloidosis, or other drugs, including some targeted drugs that are only used in certain subsets of patients, like the pill venetoclax. I do want to point out that venetoclax is not approved for AL amyloidosis, but it does seem to be helpful in a subset of patients, about half of amyloidosis patients that have a specific chromosome abnormality that we see in their bone marrow.
So people who do go to a transplant, do you, like in myeloma, we give maintenance therapy. Do you put any patients on maintenance?
Generally not. I mean, historically, transplant was a one and done therapy, and maintenance was not part um, of the treatment plan for these patients. But I would say that there is some interest in using daratumumab as maintenance now that we've proved you can successfully use it that way in non transplant patients. And I would also say that we do tend to use some kind of additional either consolidation therapy or maintenance in patients who, after transplant, still have an abnormal free light chain level. It's the same decision point here. I mean, even if after transplant, if they're in less than a VGPR, you think about modifying therapy, and that could include adding maintenance.
So what is the average period of time that a patient with who's had frontline treatment remains in remission without progression?
So with transplant, it can be really long. I mean, if somebody has uh, if somebody's a transplant candidate, they go through it and they come out the other end in a complete hematologic response, that the duration, historically, like if you look at Boston University's data, for instance, it was about 8 years median before next therapy was needed. And this was without maintenance therapy. It might be even longer if we incorporated maintenance. We don't really quite know yet with DARA Cyborg D. Um, I think most of us feel that it is unlikely to be quite as durable as transplant in terms of how long it works for, but there's also a lot less upfront risk associated with it because it's a less intensive therapy. So it's a little bit of a trade-off, right? The therapy doesn't work for quite as long, but it's also easier to get along the way. So you know, it's a work in progress. There's actually a randomized study being done right now across the United States, being run by Patrick Hagan in Chicago, and it's comparing these strategies. It's comparing Dara-Cyborg-D versus transplant in transplant eligible patients. And in this particular study, in both groups, patients are getting maintenance therapy with Darzalex or daratumumab. So that means it's going to take years to complete this study, but it will answer a very important question that you just asked. So
So you mentioned, the old data from Boston University showing even medians of 8 years, which, is a little paradoxical that in myeloma, which is thought to be a little more easier disease to treat, transplant, at least in that era, wasn't producing that level of durability.
and we see that with most therapies in amyloidosis, right? So it's hard to deliver therapy because patients are fragile. They have heart involvement, kidney involvement, liver involvement. They're a frail, fragile group of patients. So getting the therapy in is hard. And they're prone to complications related to that organ injury along the way. But the plasma cells themselves are less aggressive than the plasma cells in multiple myeloma. So if you can get the therapy in and suppress that abnormal plasma cell clone, it doesn't tend to rebound as quickly as the plasma cells in myeloma, which, as I said, is a true plasma cell cancer. Um, Amyloidosis plasma cells often don't behave really like cancerous plasma cells. So it's a difference between the ease of giving the therapy and then the benefit of that therapy if you're able to get it in, successfully.
And do you modify your approach? Because in some patients with amyloid, there's neuropathy. We also see patients who have what we call autonomic neuropathy. I've had patients who can't even stand up sometimes.
Absolutely. So, first of all, to manage those blood pressure issues that you just mentioned, a lot of times there are specific medications needed just to support the blood pressure. Um, but right, it sometimes makes certain drugs like bortezomib, that's the bor in Cyborg D. Bortezomib is sometimes difficult in patients who have neuropathy right out of the gate. Um, Melphalan, the drug that we use for transplant, in this algorithm that we have on the screen right now, it says Melphalan 200, that's 200 milligrams per meter squared. That's the full myeloma dose of Melphalan. But a significant percentage of amyloid patients need a reduction in that dose because of their frailty or because of their kidney function. So, absolutely. I'll even go one other, even more glaring example. Down at the bottom, one of the red boxes, immunomodulatory drugs. There's one here that says LEN. That's lenalidomide. The brand name for that's Revlimid. Again, it's commonly used frontline in myeloma, and the usual dose in somebody with uh, normal kidney function is 25 milligrams daily for 21 out of every 28 days, even when you're using it in combinations. In amyloidosis, the maximally tolerated dose is usually 10 to 15 milligrams. So you have to, and it's because it's not tolerated as well from a cardiac standpoint. So you do need to be aware of certain toxicities or certain sensitivities that amyloid patients have that make drugs harder to use.
So
I,
where are we headed?
Yeah, I brought this slide back up just to sort of focus in on the last three columns for one quick second. If you click on the button for me, these are newer categories of drugs,
Right.
different than the traditional chemotherapy drugs and plasma cell targeting antibodies that we have on the left side of this. Precision therapies in the middle. I mentioned venetoclax already. Um, that's a drug that's useful if the patient has a swap between two different chromosomes, chromosome 11 and chromosome 14 in their plasma cells. If they've traded genetic material, that's called a translocation. That's a subset of patients. That's 30 to 50% of amyloid patients, and those are the patients who can benefit from venetoclax. And that's an example of precision therapy where you're selecting the therapy based on something that we know about the biology of that particular plasma cell clone. We also have newer immune therapies in the blue column here. These are things like CAR T cells, which we've heard about in other types of blood cancer. These are patients' immune cells modified in a way that allow them to hunt down and kill the abnormal plasma cells. There's also a new class of antibodies called bispecific antibodies, which are much more potent than traditional antibodies like Darzalex. Very high response rates as a single agent, not as part of cocktails. And then in the very far right column, the yellow column, this is actually a really exciting area. And I think you had another speaker uh, give a little talk about this, Dr. Lynch. Um, uh, Immune therapies that actually, instead of targeting the plasma cells that are making the abnormal misfolded proteins and light chains, they're actually immune therapies that target those proteins themselves and aren't focused on the plasma cells at all. This is like a mop up. When I'm talking about this with patients, I talk about this as being the difference between the fire department and the team that comes in and cleans up the smoke damage in your house. The fire department is me giving chemotherapy or something else, directed at the plasma cells. I'm putting that fire out, but the organs have already been affected, right, by light chain production and amyloid deposition before that. And so these antifibril or light chain targeted agents, these are designed to come in and mop that up. And so you're hitting it from both angles. You're shutting down production and accelerating cleanup at the same time. And hopefully we'll see two things happen. We'll see, three things. We'll see a higher percentage of patients uh, um, have organ responses. Um, we'll see more rapid organ responses, and hopefully that will translate into improved survival. If we can make those organ responses happen quickly, patients will be less prone to the early complications that we see in amyloidosis, particularly the cardiac ones. So we're really hopeful. The top two of these, anselamimab and bertamimab, are currently in studies specifically looking to see if it can impact the cardiac risk that newly diagnosed patients with amyloidosis have because of heart involvement.
So you mentioned cardiac, just along those lines, any pearls of wisdom on carfilzomib, which has some cardiac toxicity?
Carfilzomib is not an easy drug to use in amyloidosis. Um, it's in the same family as bortezomib. It's mentioned, it's the last one in the pink column towards the left. Um, it's the most potent drug in this family, but it has cardiac and pulmonary side effects when you add those two things together in about 10% of patients. And so the cardiac effects of carfilzomib do make it a difficult to use drug. It's not impossible, and I'm not going to say I've never used carfilzomib in an amyloidosis patient, but the ones that the patients who I'd be most inclined to use it in are ones who don't have significant heart involvement. Patients who have kidney involvement maybe, or liver involvement, but not heart involvement, so that they're more able to tolerate that medication. Because if you have heart involvement and you're in the 10% that get those cardiopulmonary heart lung side effects, it's a really tough thing. So not an easy drug to use broadly, but you know as long as you're aware of these side effects and select your patients carefully, it's something that could be used in certain circumstances, not frequently.
And one thing that comes up from time to time about amyloidosis in kidney is what about a kidney transplant? Or a cardiac transplant, for that matter, has been brought up as well.
So, uh, both of those have been looked at. I will tell you that you know they've it's been looked at as a strategy to permit certain therapy, like the idea of organ transplant to make a patient fit enough to be like a transplant candidate. That's not a widely used strategy at all because I mean organ transplant is very difficult, right? And usually you're on the waiting list for a long time. There aren't enough organs. The patients are very frail, and most of them aren't great candidates for that kind of surgery. So early organ transplant is very, very rarely ever considered. But I have had patients who, after getting a therapy like transplant or Daracibor-D, if they're in a complete hematologic response and still don't have, and they're still uh, they still have serious kidney injury and end up unable to avoid dialysis despite having their light chains shut down completely. I have had patients who've undergone kidney transplant after the fact once we've gotten them into a light chain remission, and some of them have done well. I have some patients that are doing very, very well with a new transplanted kidney. So it's possible to do. Most organ transplant programs, though, demand that a patient is in a hematologic response in order to be even listed as a candidate for these organ transplants, not the other way around. Yeah.
So, what is your parting pearls of wisdom?
Well, again, this is a difficult to treat group of patients. It takes a long time to see improvements in organ function. I strongly recommend that a patient have specialists across different fields to help manage the complicated symptoms that they have. Evaluation at a specialized amyloidosis center, if at all possible, I think is always a good idea. These are the centers that are sort of best at determining someone's transplant eligibility, and also the places where patients would be most likely to have access to promising clinical trials like the antifibril trials or the precision medicine trials. And so I encourage patients to be seen at amyloidosis centers. Um, uh, you know, it's understood that as a rare disease and with not dozens and dozens of amyloidosis specialty centers across the country, a lot of patients do need to, receive their therapy locally. But most of us that treat a lot of amyloid are happy to work with local oncologists and hematologists in the management of care and to be available to troubleshoot, the complicated side effects and things that amyloid patients experience.
So I really want to thank you, Jeff, for taking on this challenging, disease and contributing so much to the advancements. Obviously, you continue to take part in trials, advancing newer treatments. So we'll be looking forward to an opportunity to have you back to tell us about advances in the future.
It's kind of you to say that, kind of you to invite me. I always enjoy talking with you, and I hope this was helpful.
Thank you very much.